Hey everybody, I know this is the last kind of bit of the conference, and at this point everybody's eyes are usually kind of glazed over and the brain is shutting down and that sort of thing, so I can appreciate that. But at the same time, the topic that we're going to be talking about, I think, is hugely important to families. It's something that's kind of near and dear to my own heart, so we definitely want to make time for it. And we've got 3 brief presentations today, but then we've also got time for question and answer. So at some point here, we'll open up the mic to people if they have anything they would like to ask, or even if people have advice for their families too, we always appreciate that. Now, I'll introduce myself real quick. I'm James Poysky. I'm a pediatric neuropsychologist. I'm also the father of a son who has Duchenne. My son Joel is 20. You may have seen him zipping around. So I've experienced this not just as a professional, but also as a parent. Now, I'm probably a better professional than I am a parent, so if you've met my kids and you see that they're crazy, that's kind of an indication of my parenting skill. But anyway, I can talk a good game. Today, we're going to be talking about what I would call psychosocial functioning, which is a pretty broad area. And today we're going to mostly focus on behavior, but it also encompasses things like emotional adjustment, academic achievement, progress learning, social skills, any number of different things that kind of fall into this category. So really, today is just kind of a drop in the bucket and kind of a brief introduction, and we really can't do justice as much as we would like. But we at least want to introduce people to this stuff. When I first became associated with PPMD about, 17 years ago? Yeah, 15 years, anyway, a long time ago. This topic was something that nobody had really kind of done much about as far as research studies, about advice for parents. And so there was a lot of work that we did in terms of educating families and providing support to families and giving recommendations to teachers and academic systems in order to support these kinds of things. But I find that it's kind of cyclical. And so it's a topic that becomes very important to people for a while, and then people kind of understand it, and then the topic kind of shifts to something else. But then as new families come into the PPMD family, sorry, that's redundant, then it kind of comes back again because people are still learning about this stuff. So it does have a huge impact on quality of life, and it doesn't affect just the person with Duchenne, but the whole family, their whole social network. And I find that sometimes the stress associated with behavior and learning and those kinds of things can be just as significant as the stress people experience about the physical side of the disease. And one thing, too, that I want to point out is that oftentimes people don't understand that this is something that's actually related to the disease itself. And I realize this probably isn't something that people here in the US hear as much, but not as much anymore, but still do international conferences. And every time that I go do a conference in another country, I'll have a family tell me that their doctor said that their son's behavior problems or learning problems weren't at all related to their Duchenne. It was something else that was causing it. And so this is still something that I think it's good to remind people of. It's good to talk about and educate parents. And the other beneficial thing about it too is that I think sometimes from the physical side of things, it feels like we can be limited in the options that we have. But with the behavioral and emotional and learning side of things, we actually have a lot of different things that we can do, a lot of supports and interventions and treatments that can provide support for these kinds of things. So today is just a drop in the bucket, and we may not be able to get into everything, but bear with me. So first up is Dr. Molly Colvin. I've known her for a number of years. She's excellent. She does a lot of work behind the scenes that you guys probably aren't even aware of that have a big impact on supporting your child. Was it 2 years ago? 3 years ago? Anyway, she was the primary lead person for developing the care recommendations through the Centers for Disease Control that have been published, and you can find those on the PPMD website. She's a developmental neuropsychologist. She's also the director of the Learning and Emotional Assessment Program, at Massachusetts General Hospital, and assistant professor of psychology at Harvard Medical School. And she specializes in understanding the relationship between learning, emotion, and behavior in development. So I'm going to hand it over to you.
Hi, everybody. Can you hear me okay? Awesome, okay. It's a pleasure to be here with you all. Thank you for being here late in the conference. And I'm going to do a pretty science-heavy talk, but then I'm going to try to make it relevant to day-to-day because I think that's probably the most important thing that we can think about. But I'm going to talk about the role of dystrophin in the brain. And I want to start by saying something important, which is that everybody is an individual. So as I go through all of this, some of this may resonate and some of this may not. But my goal is for us to all kind of come to a common understanding of how neurodevelopmental and psychiatric conditions can be expressed in Duchenne. So some with dystrophinopathies will have cognitive, emotional, and social challenges that will require support. Not all, but some. And as James was just saying, this is a really active area of research right now. There's a lot of research that's going on to better characterize the neurodevelopmental syndrome so that you can get effective treatment, but also so that we can move away from what I call the alphabet soup, which is that you get lots of diagnoses sometimes. You'll start to hear things like ADHD, OCD, ASD, and it's a whole lot of letters. But really what we're probably talking about is a single unified syndrome that just needs to be better characterized and appreciated in the role of dystrophinopathies. We're also doing some research to predict who will have these challenges to allow for earlier identification and intervention. And this is really important because, as James was saying, this is something that really has an impact on everybody's day-to-day life. And in fact, once you sort of get good management of the medical side, often these are the issues that parents are telling me are the ones that they really need to think about on a daily basis. And so I want to start with just even what we know. So a couple of years ago, PPMD did a survey, an online survey that was of caregivers, and 320 of you actually responded, so thank you very much for that. And of those who responded, what you'll see is these are the proportion of people who were saying that their child may have some of these kinds of concerns. So around half reported that anxiety is a concern. About a third reported that there were concerns about ADHD or OCD. 20%, 1 in 5, were reporting in concerns about depression. These are high numbers. These are prevalence rates that are much higher than we see in the normal population. And it really raises the alarm that there's something that needs to be addressed here in terms of discussion and also research. So I know at this point in the conference you've seen many versions of the dystrophin gene. And I know that you are all probably better versed than I am in terms of the different isoforms. But there are 3 that we sort of now know to be associated with expression in the brain. We've always sort of focused on the skeletal and muscle side of things. And as James was saying, you know, when I was in graduate school or even sort of first started working with this community sort of 10-ish years ago, I would routinely encounter neurologists who would tell me that they didn't really expect to see developmental or neuropsychiatric conditions or didn't need to refer to see me because that wasn't the way that this was expressed in the body. And what we know now is that there are 3 isoforms that really are expressed in brain. At the proximal end, we have DP427, and then at the more distal end, DP140 and DP71 are the ones that we will wind up sort of hearing most about. In the brain, the dystrophin is not expressed evenly. So in other words, some regions of the brain have more expression than others. And in this sort of slice or cross-sectional picture through the brain, what you see are the hot spots, the red spots, are where there's more expression than in the places that are cool. And 2 of the more interesting areas that were sort of first identified are a region of the brain called the amygdala and another part of the brain called the hippocampus. And they are involved in emotional expression and learning and memory. And so that was sort of a first clue that those might actually be areas of function that we would need to think about in dystrophinopathies. We also now have more information about what is going on with the more distal isoforms. So DP71 is expressed throughout development and has a role in what we call kind of glutamatergic networks. And these are networks in the brain. This is a particular kind of neurotransmitter that we know to be also important in learning and memory. So kind of connecting back in with what I was just saying about the hippocampus and also the amygdala. DP140 is mostly expressed early in development, and it may play a role in glial cell function. And these are kind of support neurons that really help when your brain is developing to kind of get the neurons into the right place and get them to sort of line up and talk to each other efficiently. And so they may have a role ultimately in making sure that the connections or the speed of the connections between the neurons is actually optimal. And both of them also may play a role in cerebrovasculature, which is an important function in terms of getting oxygen and other nutrients to and from brain regions at the time when they need to be there. So some of the early imaging studies looking at sort of both structural and functional scanning techniques showed that there were differences both in sort of cerebral metabolism, sort of how much glucose is being uptaken in the brain, but also structurally in terms of both the how many neurons were present, but also the efficacy or the efficiency with which those different systems connect with each other. So looking at changes in white matter, which is the multicolored slide at the end. That's actually sort of looking at the highways in the brain or that connect all of the different areas as they are functioning. And so this is kind of a fancy slide that looks at the differences in the white matter connectivity for those who have sort of distal and proximal mutations that may or may not impact DP140, showing that the sort of more distal mutations have more of an impact on white matter development compared to controls than even the proximal mutations. We don't yet kind of fully understand the implications of this from the functional perspective, but it's a clue that there may be differences and just in the terms of the way that the brain works in those with dystrophinopathies. So from a developmental perspective, some of the things that are more common and things that we need to look out for in the community are really differences in developmental trajectories. Global developmental delays are more common. Beyond sort of just global developmental delays, isolated speech delays are something that is also relatively common, with estimates up to a third of individuals having some delay in speech. And there can be delayed academic skill acquisition. And even outside of Duchenne and the dystrophinopathies, we often see that kids who have early speech delays often also have early academic delays because many of the early academic skills are language-based, meaning that reading and writing and spelling are all have to do with language function. So some of the diagnoses that are more common, which leads to this alphabet soup that I was talking about earlier, you can have higher rates of intellectual disability, and learning disabilities may be up to sort of 40% of individuals. This is really high. And we know that in the long-term sort of functioning of individuals, when learning issues aren't addressed early, they have a significant impact. They could accumulate and snowball over time. So it's important that we be on the lookout for these things. ADHD is also in about a third of individuals, and there are higher rates of autism spectrum disorder than in the general population. And then I think ones that have been understudied but are kind of increasingly being appreciated relate to anxiety and also OCD. This is also a busy slide, and the primary difference here is that they were intending to show the difference between the rates in proximal versus distal mutations. I don't know if I'm going to be able to get a pointer, but the idea is, let me have to turn it on, let's see. Nope. It doesn't go quite that far. But the idea here is that if you're looking at sort of overall IQ scores, what you see is that there are higher scores for those who have more sort of proximal deletions than the more distal deletions. And the same story is really true for neurodevelopmental symptoms, for symptoms related to autism or inattention or learning issues. You tend to see that those with proximal mutations are less affected. The story is somewhat similar in Becker, although I would say that this has not been as well characterized or studied, but you'll see sort of similar rates of neurodevelopmental disorders in Becker as in Duchenne. And here again, there's less to be known around the differences in mutation. So this is probably not, this is an artifact more of there not having been as much research. In terms of psychiatric symptoms and the things that we sort of think about and pay attention to, again, it's anxiety and OCD features as well as depression. But I think one of the things that I hope we'll spend some time talking about today, because it's something we hear so commonly from parents, is around mood and anger and oppositional behaviors. and that these are more common, and they may actually relate to some of those structural differences that I was talking about earlier, especially with the amygdala and emotion processing and fear. Again, busy data slides, but some of these busy data slides are basically saying that in the case of psychiatric symptoms, when they look and compare proximal versus distal mutations, there seems to be less of a link here, whereas the cognitive story is pretty clear about it matters where your sort of mutation is. In terms of psychiatric symptoms, it seems to matter less, but this again is an active area of research. So I'm going to go through these actually. So sort of moving, one of the things that we've been trying to do, and I know I've had multiple conversations with my colleagues here on the stage about this, is sort of moving towards something that's kind of what we call transdiagnostic, meaning it's not talking about one diagnosis, not just talking about ADHD or OCD or anxiety, but talking about a neurodevelopmental syndrome that's associated with dystrophinopathies that has these characteristics. And not all of these characteristics may come together in an individual child, but we know that these things may be more likely to co-occur. And these are the things that we need to be thinking about and looking out for, especially in the early years and as children are sort of coming through preschool and into elementary school. These are the kinds of things that we really would like to be flagged earlier and earlier, and that's going to be through dissemination of knowledge. So the things that we're sort of looking for that sort of seem to always kind of hang together are some mild delays in overall cognitive functioning with weaknesses in attentional regulation and executive functions, as well as some difficulty with learning and academic skills. There can be social communication challenges that will overlap with those that are typically seen in autism spectrum disorders. And then there can be anxiety with OCD features, as well as anger outbursts and oppositionality. One of the things that we're going to talk about today is really this kind of relationship between how you process information and how you feel, and then how you behave. So as we think about this kind of constellation of symptoms that may make up this kind of syndrome, I think it's really important to think about the relationship for this in terms of understanding what you see every day. So for example, if you have a child who has learning concerns, they're really struggling to read or to write or to do their academic work, that can create anxiety, particularly around school. And then once that anxiety is triggered, a very normal response to anxiety is avoidance, or sort of wanting to stay away from it, or not going to school, or not going away. So you can kind of see how you can get this interaction, because then once you start avoiding, it just exacerbates the learning problems, right? So you sort of see how this cycle and this kind of circle gets triggered by issues in one area that then cascade into another. So here's another example that many of you may resonate with. So my kids who struggle with cognitive flexibility, they can be a little bit rigid or sort of stuck in their ways, or they like their routines. They often sometimes will get sort of stuck in their thinking patterns too, and have some repetitive thoughts, right? So they kind of get stuck behaviorally, they get stuck in terms of their thoughts start to go around, and then they have a very hard time sort of shifting somebody and to see somebody else's perspective. They kind of get locked into their way of thinking and doing things, and it may take a little bit more time and effort to shift them to sort of think about a different way of seeing or doing things as well. From a therapeutic perspective, understanding this interaction is really important, because then you're going to need to know at which of these stages you're going to intervene or what's driving the behavior. So the trouble shifting isn't because they're not interested in you, or they don't care about you, or they don't love you. It's really that they're getting stuck in their thinking patterns and having a hard time shifting. And once you sort of understand it from that angle, it's much easier to sort of then reconnect and figure out where you're going next. With all of these things, it's always important to think about the whole child. So, and I started this talk even saying about the importance of the individual child and knowing who they are. And it's more than genes, and it's way more than sort of just this alphabet soup that I'm sort of talking about. But it's also important to think about the role of the external environment and sort of moving in development. It's an interaction between the environment and genes in every child, and that's especially true even in Duchenne. And so I think it's important to kind of think about the whole, what you can do from a community perspective and from a family perspective to sort of shift and move things so that you have optimal development. So some of the key takeaways that I'd like for you all to leave, and I hope will sort of set the stage for the conversation that follows, is that dystrophinopathy can be associated with a neurodevelopmental disorder that is in psychiatric concerns that have likely been undertreated and underrecognized in the past. And there's an increased risk of these with the distal mutations, which implicate sort of DP140 and DP71 as playing a significant role. And the impact of these proteins may vary depending on where you are in development and also where you are in the brain. But the major characteristics may be a mild delay in cognitive development, and then there may be sort of more specific concerns around language and communication, attention, and executive functions, as well as learning issues. And that there is also perhaps increased psychiatric comorbidity related to anxiety and OCD and perhaps depression, but more commonly sort of anger outbursts and oppositionality. And the incidence to mutation may be less clear here. And the overlap with other neurodevelopmental disorders suggests that there's involvement perhaps in the subcortical networks that connect to the frontal lobes, which typically develop over the course of childhood and adolescence. And the good news about that is that gives us a long runway to do intervention and to sort of promote optimal development. But as you sort of move forward in your communities, I think one of the things that we're really actively working on is promoting a concept of dystrophinopathy as being more helpful than a conceptualization necessarily of DMD and BMD, but sort of a unified dystrophinopathy that it may be associated with its own kind of characteristics in terms of a neurodevelopmental disorder. So I want to thank you all for listening, and I'm going to turn it over back to James.
That was excellent. It's like drinking from a fire hose, but excellent. Good job. All right, so, excuse me. Up next, we have Denise Gruender, and for the past 30 years, she's owned and operated a school for special needs children focusing on language delays and sensory issues. And she's been a part of the PPMD family for many years. I won't specify that. But she's known Pat Furlong for a long time and has really been of significant help to a lot of families dealing with behavior concerns, problems in school. And the thing that I like about Denise is I think sometimes as psychologists, we have a tendency to kind of speak in overly vague terms or kind of get stuck in esoteric ideas. But she does really well in helping with families, giving families really concrete, practical things they can do in the moment when things are starting to fall apart. So I'll hand it off to you.
Thank you. I have been spending the last 3 days with your wonderful children up in Kids Track, and we've had a blast, and I've seen just some major growth even just a few days. So it's been an absolute delight, and I've enjoyed talking to several of you over the last few days in our one-to-ones. But I did run out of a few time slots, and I've caught a few people asking for some more. I am free all year long, and I don't mind at all. If you want to call and chat, it's like Christmas when you want to buy your child, the new tennis shoes. Well, they needed them in March, not December. You're going to have behavior problems all year long. So I'll be there, call me, and we can brainstorm early in the morning before they wake up or late at night. So as you well see, behavior. They all behave differently. They learn differently. They speak differently. Every one of them is very extremely unique. So therefore, they need different approaches. And so every school, we send them to school and we think this is going to be a great year, and it falls apart in the first week because you have a classroom of 25 and they all need to be taught individually. And then our children especially need a little bit more hand-holding, which is how I started a school 30 years ago for children on the spectrum with language delays, ADHD, ADD, processing, everything that Molly just mentioned. So again, it takes us a while, and it's taken every year. We have to customize our program to your individual child. But I think every parent at our school is doing what you're trying to do. Figure out the best way that your child can be successful. So my dream is that you won't have behavior issues till they're 14, 15, 16, and then you have those teenage attitude issues. But unfortunately, we have problems along the way. And I'd like to say that we're going to start at age 3 and we're going to come up with a behavior plan and we're set to go. Well, I would be lying, because every year every month, you're going to have to try with a different approach and come up with some new ideas. So I'm going to generalize, but I'm also going to give you a little bit of a disclaimer. I'm not a PhD. I'm not a doctor. I'm a teacher with a lot of background in learning disabilities and a lot of experience for 30 years watching these children. These are things that we've watched every single child. We take 30 to 50 students every year, and then in our summer school, it just continues to grow because the children get into a main regular classroom and then come back every single summer. But every summer, they're a little bit older, but we have a little bit bigger problem of a behavior. So these are things that we've tried over and over and over, and we've just come up with new ideas. So the things we've learned, and again, these are just things we've learned day in and day out. Tantrum versus meltdown. Learn your child. It takes a while, but it was quite comical to me. Excuse me. I watched you parents today. A few of you said to me, wow, I know what you mean, a tantrum versus a meltdown. A meltdown for us, they can't handle it. We teach new information. We show them something new. And as Molly mentioned, that anxiety, whoa, they just freeze up. And when they can't handle it, whew, they throw themselves down, they bang their head, they hit someone because they don't have the words to say, hey, hush, I can't take that in right now. So when they melt down, it's a whole different situation than a tantrum. Tantrum, I'm mad, I'm angry, I'm frustrated, you're ticking me off, and I'm going to show myself. But watch. If Molly right here is melting down, if she's having a tantrum and she's throwing herself down, and I say, Molly, oh my goodness, you know what? I've been wondering, how does moss grow on a tree? Molly all of a sudden goes, what? She's been screaming and crying, and now she says, what? So we do this all the time. When they can stop instantly, I don't know how moss grows on a tree, and now they're all involved in it. Guess what? We're just having a meltdown and we're showing ourselves. So when we start with that kind of behavior, start learning and come up with some brain breaks that you can teach your child to snap right out of that. A meltdown, they can't snap out of. They are melting down, and no matter what you do, you can only catch them in the calm phase. There's 6 stages of a meltdown. You can catch them in the calm and the rumble, but then the next 4 stages, you've lost them. You cannot reason with them, but in a tantrum, if you can break it, you can. And we can definitely see the difference every single day. And I lost my clicker. So, how do we fix those? Children crave structure. And I'm going to almost promise you that you're not giving enough structure if we're having a lot of meltdowns. And that's easy for me to say, I'm not in your home. But if you can think, okay, am I really doing enough structure? Every little part of your day, they love to know what's coming. They love to know what they've already accomplished. If you get in the car and you say, we are on our way to blah, 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 and this is what we're going to do, it will help your day. If you tell them in the morning, this is our day and this is what we're going to do, it just is a great motivator to get through their day. Okay? And I'm going to show you a few things later to talk about some of those things. Now, a parent doesn't always see what a child is truly capable of. Our children eat at school. We have kids up through 5th, 6th, 7th grade if they're in our summer camp, and during our school years only through 2nd grade. They eat lunch at our school, and they eat all kinds of things. The parents come to us and say, no way, did not eat. Because they know your mom, they know your dad, they know they have unconditional love from you. So push them in places where you're allowed to push them, where you're not there watching their every move. So try new things and ask the people that you're close to. Okay, am I missing something? Do you think he can do better or worse? Find the people that you trust, that you can see that your children can do a little bit more than what you're expecting. We can't always hold it together in two places. Holding it together at home and at school is a long day. You don't always hold it together at work and at home, so we expect our children to. So sometimes they just need to let their hair down, and that's okay. But you have to help guide that. Love is blind. Yep, you get married, love is blind, you don't see all those faults. Same thing with our kiddo, sorry. Our kids are the same way. We don't see their faults because they're amazing, and they are truly amazing. But look to people outside to talk about what am I missing? So our rules of daily living, and I'm going to talk about a rule wall in a minute, but our rule walls, are you really getting consistent sleep? Now we add all the steroids and every other kind of medicine in there, and sleep is difficult. But I will tell you, going to bed at the right time every single day is amazing. Now, once they get a little older, they want to stay a little bit more awake and play a little bit more at night, try to watch that. It's just huge, and we see it all the time. If you're having to wake up your children in the morning to go to school, easy for me to say, I'm not on steroids. But let's try to get to bed a little bit earlier. So again, this is easy for someone who's not living in your shoes right now to say that. Eating and feeding, this is huge. I had 4 parents today ask me about eating and feeding. What do we like to eat? And I'm talking up through some of you for 2nd grade. Chicken nuggets, mac and cheese. Strawberries was one of them today. Who was that? Strawberries. We have a limited diet sometimes. If you're on a limited diet, please see an eating and feeding specialist. It's very hard for you to win on that. Now, I can save you a couple $100s by giving you the first steps of the eating and feeding therapy. I can show you what you can start with at home. Call me. They have my number. You can email me, call me, text me, and I'll get you going on your eating and feeding and probably save you the first $500 in therapy. After that, you really need a therapist. They are amazing. They will get your children eating things early. And if you haven't reached 1st or 2nd grade, you still got a lot to do, and you can make a lot of changes. Once they start getting into those school ages, it's a little hard to change their eating and feeding, and we want to get well-balanced meals in them. Consistent rules. Sometimes we have mom and dad living in 2 different houses. Sometimes we have mom and dad just not on the same page in the same house. We have nannies. We have grandparents. If we could all have a little everybody in one room, and let's all talk about how we can make consistency for this child, it's huge. A couple parents said to me today, yeah, grandma just, well, grandma is grandma. She's easy. But if you really have a come to talk with grandma and say, I really need you to follow through with this, it's going to help everyone. And I'll be glad to be your mediator on that conversation with grandparents. Because once they really know what's happening, they want to give them a little extra cookie. They want to not just cuddle them when they cry. We need a lot more structure. Structure, schedule, we got that. All right, a few things, and again, I've spoken with so many of you today. The visual timer, it's just huge. And this only gets you through about 2nd, 4th, 5th grade. After that, you're on your own. But I have, my children were still using visual timers through college just to motivate themselves to study. I'm going to set it for 15 minutes. I'm going to study, and it will help because our minds, they have to see an end in sight. And once you can see an end in sight, it sure helps. You might want to do this just to get through your day. But visual timers, going to the park, when you're leaving, you say, we have 5 minutes left. Pay attention and set that timer. You can buy them in every size. Time timers, I should be like on a commercial. Time timers are the ones that seem to hold up the best. Bumpy cushions. I have 2 employees that use bumpy cushions, as well as our students. In a chair, when they're in chairs, and when they're in just a regular chair at school. Bumpy cushions just give us a little bit of air to wiggle around, and it helps us get us through the day. I want every child sitting at dinner for 20 minutes. Some of you are going to look at me and say, you're right. There's no way my child's going to sit at dinner at 20 minutes. If you set the time timer and you get a bumpy cushion, keep pushing that. But I'm not going to tell you your child can sit for 20 minutes until you see a therapist who can confirm that. Then you're going to know they can, and then you have to follow through. But sometimes, again, somebody outside of your house needs to tell you, yep, they sit, and they need to continue to. We have a rule wall, and we do this with most every family, and even in our private therapy. You have a rule wall, and the best was a mom that came to us after we had told her this. She has an entire file that she carries around in her purse, and it is a rule wall for everything they do. She pulls it out of her purse. Oh, we're on our way to the park. Here are the rules. If you hit a child at the park, we are leaving immediately. If you do this, and we pre-talk rules no matter where you are. But one of the biggest rules all through high school, our family room, our kitchen is our family room. We don't cry, we don't scream, we don't yell. If you need to throw a tantrum, if you need to have a meltdown, you can, but you have to go somewhere else because that's our family room. So we do this at school too. Ask your school with those behaviors. Maybe we have a little room that they can go to. They're not allowed to melt down in the school, in the classroom. They want attention, and we don't want to give them all the attention. So create a rule wall, whether it's on a poster, an eraser board. This lady had laminated all these sheets, and she carried them around with her, but they worked. So again, these are just little ideas that you need to then hone in and make it work, make something that work at your house. Visual schedules. Okay, visual schedules, all you have to do is create a schedule that they can follow all day long, and that's again what I talked to you about. Behavior plans, contracts, charts. If we talk at home, share with them what you're doing at school and share with school to home so that you can have rewards or systems that will help. Brushing, squeezing, quiet reading, you have to find something that gives them a little bit of warmth and fuzziness to get through the day. Preventative behavior is absolutely everything. So, try to learn more of what is triggering, find the key ideas that work, and you cannot discuss a meltdown until at least 2 or 3 hours later. And if you can discuss it later, you're going to find so much success of how you can avoid the next one. Teach your teachers. If you find things that work, talk to your teachers and help them create a plan for you. Describe what works. Try to be ready for this. Don't try to change all at once. I asked James, what helps you and what did you say? These are his comments. Compromise, everything doesn't work. Choose your battles. Make it practical and realistic for your family. Good luck. I'm a phone call away, and I hope I can help you.
Great job. And the last speaker is Natalie Truba. She is a clinical psychologist at Nationwide Children's Hospital and specializes in managing behaviors and emotional adjustment in kids who have complex medical conditions and neurological disorders.
Oh, it's like a tough 2 hours to follow. Yeah, that was a great presentation. Got it. All right. I'm going to go through logistics a bit today, so to provide some education just about our world, because it can get really messy. There's lots of types of psychology. So the reality check here is that the default is that there are going to be problems when you have dystrophinopathy, not that everything's going to be good, okay? So it is what it is, and we want to be proactive and we want to stay ahead of it. So when, where, and how do we intervene? That's what I'm going to be talking about today. So when do we intervene? At the first earliest sign of problems, when things are significant and impacting functioning, okay? As soon as you start to say, this is getting in our way of how we're living life, how we're doing things, that means we want to get that addressed early. Don't say, oh, maybe they'll grow out of it. You know, this is Duchenne and Becker muscular dystrophy. They're not going to grow out of dystrophinopathy. That's not how it works. And so we want to get in there early. So when you're seeing your pediatrician, they're like, oh yeah, don't worry about it, we'll just watch it for a year. No, we want to be aggressive in this population. You see a problem, we want to get linked early. What's impaired? So this is really, really important because as Dr. Colvin was talking about, and that we know that there's a big impact on how the brain not only develops, but how the brain functions. And that means that there might be problems that are primary that cause secondary issues. And sometimes the secondary issues are when we actually start to see it, right? Because then we're like, oh, you're really struggling with reading, or you're struggling with language. And that might stem from an attentional control issue, right? Because if you don't have good attention, you can't focus, it's harder to learn. But that can fly under the radar. And so we want to be really, 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 again, thoughtful and staying ahead of and making sure that we're addressing those primary issues, even if we identify a secondary issue after the fact, right? We still want to come back to that and say, is there something that maybe is driving this that we can address? Because we don't want to have to be like whacking that mole, as people were talking about yesterday, and chasing secondary problems because we've never actually addressed this primary problem. Where do we intervene? Well, you want to tell your neuromuscular provider when you've got things going on, right? You want to tell your PCP. They both need to know, okay? I can't tell you how many times in our clinic we have people that will tell us problems that they don't tell their PCP problems. Well, PCPs, you see them a lot more often, and they can facilitate all the referrals, and they know in your area and maybe who they would work with that would be a good fit, or that is going to be able to achieve the thing that you need to be achieved. Your neuromuscular team, though, can certainly provide guidance to your primary care physician team around brain dystrophin and the way brain dystrophin impacts emotions, regulation, physiological regulation, learning, and sort of behavioral regulation. And then you want to think, do we need to start to think, is this an individual issue? Does my child need an individual intervention? Is this a family system? Something in our family system is going on that's making this worse, keeping it present, not allowing it to resolve? Is this something that we could address through the school system? And then you want to think, how do we have continuity, right? Because if we can't just address a behavior issue in one spot if it's occurring in all the different places of our life, okay? Likewise, if you have a behavior, you're like, oh, it only happens when dad's home, and it only happens at school, right? That shows you then some level of control, and that needs to be, that needs to be explored, right? Because a lot of times people say, oh, they don't have control over it. I'm like, it only literally happens in this one area, they have control over it, okay? Think about a seizure disorder. It happens randomly, you have no control over that, it just boom, you're having a seizure. If your behavior is only happening in certain times with certain people in certain contexts, that shows there's something about that context they're learning those behaviors in that are maintaining that and keeping them going and making them worse, okay? So we always want to ask ourselves, is this a can't do problem or a won't do problem? Because they have very different interventions, okay? How do we intervene? Well, there's a lot of different types of interventions, okay? So I'm going to talk about the different type of evaluative interventions. This is where we're going to spend the majority of our time today. We have neurodevelopmental evaluation. So this is an evaluation done by a clinical psychologist, which is somebody that has a PhD or a PsyD in psychology or psychological sciences. And they have specialized training in the evaluation of individuals with profound or severe developmental delays and or autism spectrum disorder, okay? So when you're worried about things young on, you might want to go to your primary care and say, I think we need a neurodevelopmental assessment. My kiddo's, under 4, and I really want to make sure that I'm getting this addressed, and I want to get to the right person. Because it is frustrating, and it breaks my heart when I meet families that are like, oh, I've been in this wait list to get this evaluation for a year. I met with them and they're like, oh, this isn't the right place. We're going to send you this other place. And they have a 2-year wait list. And now we've just lost 3 years of intervention time. A neuropsychological evaluation is also done by a PhD in psychology, either a PsyD or a PhD, and they have specialized training in understanding brain processes, how the brain functions in the context of healthy brains that are dealing with illnesses, and how that maybe impacts different brain systems. And they are super helpful in this population. We actually recommend that you have a neuropsych evaluation every 3 years, right? Because it's really important that we're watching how the brain is developing, how the brain is functioning in the context of dystrophinopathy. We have psychodiagnostic evaluations, which would also be done by a PhD or PsyD in psychology, somebody with a doctorate in psychology. And what they do is they're looking at elucidating or clarifying the diagnostic picture. Is this ADHD? Is this anxiety? Is this depression? Is this maybe a learning disorder we need to flush out? So that can be a really helpful evaluation if you really need some clarity around maybe what is driving some of these behaviors. In this population, it's less helpful. I would recommend going to a neuropsychologist over doing a psychodiagnostic because of dystrophinopathy piece. So if you get recommended to do a psychodiagnostic evaluation, I would push very hard to have a neuropsychological evaluation instead. They also do evaluations at school, or academic or IEP evaluations. These are not necessarily diagnostic, but they're to help guide how they are going to structure learning in the school system. They don't have to accept outside neuropsychological evaluations. They will often do their own and supplement and use outside evaluations to help guide some of that, but they're separate, they're different. So you don't just get one and you're like, oh, why can't you just use this to do an IP? The laws are kind of unique in that school system, and so often you'll see kind of both are happening. You can always ask for an evaluation to be done at school, and legally the school has to respond to that and meet with you and kind of go through that within a certain amount of time. There are also a lot of other disciplines outside of psychologists that can be super helpful in getting in quick to start to get this ball rolling. Occupational therapists, speech and language pathologists, early learning and intervention specialists that really specialize in that development of children under 3 years old. And getting in early, getting good evaluation, and starting to address these skills very aggressively is going to help our boys catch up and reduce some of this gap that we see in language and learning in that early elementary age. Likewise, there's all sorts of types of psychotherapy interventions. We have individual psychotherapy, where you're working one-on-one with a therapist. This might be one-on-one, traditionally like what you would see in TV or the movies, where you go into an office and you're meeting with somebody like me or somebody like Dr. Molly, and we're working on problems that you want to work on. It might also look like feeding therapy. It might also look like behavioral type of activation or intervention that was really working on scheduling and getting moving or getting activated again. So individual therapy can be very helpful if that aligns with what the underlying issue is. We have family-based therapy, which is really working on the family unit, the family system. That could also look like the family coming in like an individual session, but we're working on how we're all functioning together to make changes or modify how we're living in order to improve our quality of life and our behavioral health functioning. Family therapy can also look like home-based therapy. It can look like feeding therapy. It can look like all sorts of things. But the goal of family-based therapy is to include the family in order to address the underlying problems, maintaining behavior at a systemic family level. And so if you are one of those families, you're like, we do things real differently. My partner does it this way, I do it this way. Family therapy is really helpful with that because these boys thrive on consistency and structure and predictability. And if you are doing things different, it's not predictable. And that's very stressful to them. There's group-based, right? Where you're going in, there's a group of people, and you're all kind of working on different things, but in a shared similar space. It might be mindfulness, it might be talk therapy, it might be CBT, but you're using your own experiences and sharing them and to learn from other people and develop flexibility and perspective in a way that you don't get in individual therapy when it's just you and an individual therapist. There's a real power to learning through other people and their experiences and how they are addressing and navigating their own issues. And sometimes your issues don't look alike at all, but you'll be like, oh yeah, that resonates with me. Like, yeah, like that's really similar even though it's really different. And that I'm gonna try that strategy. So group therapy can be really helpful if you're somebody that really kind of likes to have a lot of different perspective and bring that in. There's intensive outpatient. So this might look like you're going into a center and you're gonna receive individual therapy, family therapy. You're gonna go maybe every day. You're gonna stay there for 6-7 hours, but you're gonna go home and stay at your house after that. But you might do that for a month, you might do that for 5-6 months, you might do that for a year. The goal is to address problems in a very stepwise fashion. Sometimes when we have kids who have been out of school for a long time, they're very incredibly avoidant, we have intensive outpatient programs that get them back into the school setting and address that in a couple months and to address that. So it's not always a severe mental illness, but also anxiety and other things that are causing big barriers to things like learning, like we're not going to school because we're so anxious. There's also inpatient, right? And this is for when we're not confident we can keep ourselves safe or we're worried that we might hurt somebody else. Inpatient services are really, really important because it allows us to be very aggressive in how we think about medications and therapy in order to get things addressed, get us linked with outpatient, and kind of get this ball rolling, right? In our population, it can get challenging with inpatient admissions because a lot of inpatient mental health floors or facilities are not necessarily going to be able to accommodate the medical complexities of our patients. And so then it means really partnering with inpatient providers and making sure that if your child gets admitted to the hospital because of an emotional, behavioral, or psychiatric issue, that you are really, demanding psychology, social work, getting them linked with good outpatient services, and making sure that we're doing that floor level stuff that they would be offered on that psychiatric floor if they were able to be accommodated on that floor. There's also a lot of non-formal ways to intervene. And I think this is really important. And this is a really esoteric example because we have this in Columbus and we're very resource rich in Columbus, Ohio. But one of the things we have, for example, is we have a sketch comedy group and they have special outreach for kids with medical complexities and disabilities like Down syndrome, autism, other things that make it hard social, emotionally. And they have this group and the kids all get together and they practice social skills in a way while they're learning sketch comedy, and it doesn't feel like therapy. They're learning how to think on their feet and use humor and diffuse situations by developing a skill set through practice. And they may only have a few that they go to, right? They have like 4 or 5 ways that they like to, that's better than 0, right? And so there's ways that you can think about leveraging, how do I get these skills for my kiddo that I want to get that don't necessarily have to be formal, right? But they have to be intentional and thoughtful. Thank you. Oh, that's fine.
Great job. That was an excellent job. Thank you, everybody, for your participation. And I just wanted to point out, too, that on the PPMD website, there are a number of resources addressing behavior learning, emotional adjustment, that sort of thing. Also things that you can give to the school to help facilitate any problems that are happening there. So we have a few minutes left before it's time for the next session. So I guess we can open up. I think we got microphones, don't we? Anybody have any questions for the panel or any comments, or does everybody just want to kind of take a nap or something? No? You nailed it, I guess. Yeah, perfect.
Wait.
Oh, we got one.
Wait.
Okay.
Hey, so I always like to start stuff because then I figured somebody maybe will come after me. I would love to hear your thoughts on how you have woven, if you have woven, meditation practice, which of course is exploding all over the place, into these behavioral situations. I certainly have an answer to that question, but I would like to hear your answer to that question.
Mm-hmm. It's really hard to understand.
There's a lot of
echoey, so.
She was asking, to what extent do you incorporate any meditation practices, or I'm going to throw in mindfulness training as part of that?
Yeah. It depends on the guy, honestly. There are some that really respond well to that and really enjoy that. There are others that it's really hard for them to do that. And so we might start with some basic like body mindfulness practice and extend that into more meditative or cognitive metacognition mindfulness activities. But the mindfulness piece is super helpful when it comes to training thought awareness and helping them get out of that perseverative thought loop sometimes. But because they have attentional issues, sometimes we have to actually train the attention piece first so in order for them to actually be able to do and engage in that practice. And so what we'll do is have them, I do a timer system, and we'll start with wherever we can kind of get attention, and we just build up that practice, and sometimes it's like a minute, and we're doing like mindful breathing. As soon as they start to talk, we're like, oh, we're gonna start that back over, and we gotta get through a whole minute, and we're just training that ability to attend, because if you can't focus and stay in that space, then it's really, really hard to benefit from those types of skills. But they can be incredibly helpful, mindfulness skills, especially when it comes to the body-thought relationship, but then being able to stop, recognize our thoughts, and engage in a practice that helps us get ourselves out of those perseverative thought loops.
Thank you. The question that I have is, how do you separate the kid from the drugs?
Sorry, say it again.
How do you separate the child from the drugs?
From
How do you recognize when a drug therapy is a causal factor in the child's behavior versus this is the way it is because my child has DMD and he's on prednisone?
Is it a side effect versus is it neurological or developmental
Exactly.
sort of?
Yeah.
Do you want to take that, or you want me to?
Go ahead.
Okay. I think it's a great question. I mean, I think that we have to think about the whole system. One of the ways that I would think about it is knowing your child before the medication was added, and then watching very carefully sort of during the period where the medication is sort of increasing in the system or coming to efficacy. And then I think that, you know, if you're starting to see sort of negative side effects at that point, then it's worth having the conversation with your physicians about it. We do know that some of the medications that are used, steroids I think most commonly, will sort of change the threshold around sort of mood and stability, emotional stability. But sometimes that's also, you know, there's always a trade-off, and I think sometimes you have to sort of think about kind of the cost and the benefit of the medication. But it may also be that, and I'm not a psychiatrist, I sort of have to sort of say this, but in talking with some of our psychiatry colleagues about this, adding medications that are around attention and emotion and anxiety can also be really helpful in addressing some of these concerns that may not just be about medication, but may actually be about the way that the brain is functioning. And it may take sort of a combination of medications to kind of manage things optimally.
And I would add to that, I would say that usually by the time people come see us in clinic or whatever, usually at that point, that's already been taken care of, because when kids are first started on medicine, the reaction is so dramatic if it's going to be a problem, that usually that's either been worked out or it's been discontinued. So oftentimes that's kind of already been ruled out before they come see us, but
Yeah,
not always,
I would agree.
oftentimes.
James, can I add something?
Oh, sorry, I missed you.
Hi, Dr. Truba, this is for you. I know you've done some work around carrier moms and sort of how, I think you said we can be sometimes the worst person to deal with meltdowns and other issues because we can struggle with those ourselves. And I'm just wondering, what are some of your kind of your advice or your tips for us as we're kind of navigating our own sort of issues with, you know, maybe anxiety, maybe a little bit of OCD and other types of some of these other effects from the dystrophin.
Yeah, thank you for that question. We need to take better care of our carrier moms. That is the first thing I will start with. When we do biofeedback with boys, with their carrier moms, they have very similar, albeit less maybe intensive or sort of significant swings in their physiological profiles. And so in order for you to be your best self for your child, if you're a carrier mom and you experience anxiety, I honestly have not met a carrier mom that hasn't told me that they have experienced anxiety in some capacity or been treated for anxiety in some capacity. Take care of that, because children and parent dyads are very interconnected, and you feed off each other. And if you are not a good version of yourself, it's going to be really hard for your son to regulate as well and function as well and calm as well. And so your anxiety management and your own mental well-being is incredibly important, because the same experiences of what happens for these boys and what makes them, their brain-body regulatory capacity not as maybe as efficient as mine is with making all the dystrophin, is very similar. And if you're not working on that yourself, that can actually really make it that much harder when you're trying to help your son calm down, because you're going to react to that, right? Your body is reacting to this stressful situation. And if you're reacting and you're getting physiologically aroused again, your son is going to be physiologically aroused with you, and it can be hard for them to shut down. And so sometimes like bedtime is a big one, because the boys are really tired at the end of the day, and it can be hard for them to wind down, and they don't want to go to bed, and they're melting down. And carrier moms are like, I don't know, it's like the worst experience of my life. And sometimes we just switch it. We're like, dad puts them to bed, and you're like, it just goes better, right? Because the dads aren't carriers. They're not experiencing the physiological dysfunction in the same capacity. And so it's easier for the boys to simply just calm naturally and be able to fall asleep a little bit better. And so being very thoughtful, if you're a carrier mom, about, am I the best one to do this right now? Not just because like your mom, but just like my body doesn't regulate as well, just like my son's. And if he's melting down, then I maybe need to step away and let someone else kind of help me right now, so we can both get out of this and like move forward.
Also on that, James, back to the medicine as well as the meltdowns, we've started charts at our school that go from home to school, school to home. And we ask that you don't tell the teacher directly that you've started a new med, that you tell the office, so that we don't look for that new med. but the office knows you're on a new med, the office knows you're trying something different. That way we know in the school that you're there, but the teacher isn't looking for it. But then we track all day long when the meltdowns happen, when they're frustrated, if it's towards lunch, after lunch, and how long it takes for a new med to kick in. But we start these charts day one.
So what's your plan for getting one of your schools in every state?
Oh yeah, we'll do that soon.
Yep, good, thank you. I think we got time for one. We're running a little bit past time, but we got time for.
Then I guess we've talked quite a bit about managing behaviors or like kind of waiting out meltdowns as the result of what the kid is experiencing. I'm wondering if there are any suggestions or kind of sources that you all would recommend for ways we can actually modify a kid's environment to actually just lessen demands or prevent putting them in situations that are harder for them to navigate, kind of helping to accommodate kids within their environment.
Yep, no, I think that's an excellent point. I mean, kids' abilities, there's a ceiling as far as kind of how they process things and what kinds of situations they can manage and that sort of thing. So there does have to has to be approached from both directions. But that's a broad question though, right? So what I would say is, for each of you, what is your top one accommodation or modification of the setting or the context that you typically make most often to families as far as something to try at home or at school?
Oh, I have to choose one.
That's
Pick
a
one.
tough question, James.
That is a tough question.
Because I find me after this, because I have a whole bunch. Because that's where I operate the most with a lot of my families, is on the environmental pieces, because that is one of the best ways to bring more control in from a stimulus control standpoint, contingency management standpoint, in order to do more proactive trigger management. I guess would be the one that I work on the most from an environmental standpoint, is setting the environment up to reduce those triggers or make them much more predictable, so that then we can navigate them better, get out of them better, reduce frequency, shorten that latency, or make that latency bigger, shorten that frequency and that severity and that duration of those meltdowns. Because it's going to happen. We just want to make them less horrible, less often, and less severe. So yeah, find me after this. I got a whole bunch.
I think mine would probably be more about helping people to check their assumptions, whether that's parents, caregivers, teachers. I'm going to borrow a saying from some colleagues, Alicia Pilastri, who does collaborative problem solving, and Stuart Avalon, and they talk about kids wanting to always do well. If you sort of approach with the assumption that they will do well when they can, and if they're not doing well, then it's because there's something about the environment that needs to be shifted, then that's a much more sort of helpful framework than sort of thinking that they're just doing something to be intentionally difficult or challenging. Even those challenging behaviors in and of themselves may be sort of driven by difficulty kind of navigating the environment. So I think probably the one that I work on the most is really about kind of helping people to understand how the brain works in different kids, so that we can find their strengths and find the things that they're good at, and if they're struggling, sort of identify where the weaknesses are, because the behavior is really a manifestation of a struggle, and we just have to uncover the struggle and address that to sort of reduce the behaviors.
And we ask that you pre-teach. So we give you a note every week what we're teaching. In reading, we are learning the ER sound. In math, we're learning this. And if you can mention it at home, if you can pre-teach any little bit of it, even at dinner, you discuss it, then they've already heard it. So when they hear it in the classroom, it's not total anxiety, because that's what happens, and then you just build, and then we melt down. So the children that we see have been pre-taught just a couple words, less meltdowns.
And I would kind of add on to all of that and say that I think the thing, in response to your question, a general recommendation that I make is make sure that your expectations are realistic for that child based on how they usually do, not based on what they should be able to do for a kid their age, because they may not have that same ability level. So let the way that they typically do, let that be your starting point. And then, you know, kind of, you can push them out of their comfort zone a little bit, but if they're never able to go to the grocery store and be patient for, you know, 20 minutes even, well, it's probably not going to happen for an hour today, right? So you have to kind of really have some grace for that, even though it is kind of, it can be a challenge sometimes, but I think having some flexibility as a parent is really important, and adjusting our expectations so it's realistic. I think that's a big one, and when it's unrealistic, that's the biggest source of frustration for both kids and parents, I think. All right, good enough for today? All right, thank you everybody, appreciate it. Thank you to our panel members.